I am so honored today to be interviewing one of my newest medical advisors, Dr. Stacy Tanouye. She is a gynecologist in the Jacksonville area. It's just such an honor to be with you today because this is such an important part of my why, Dr. Stacy. As someone diagnosed with no family history, getting normal mammograms, the gynecologist plays an incredibly important role in breast cancer. It's really an honor to have you, and I know we're so grateful. Can you tell us a little bit about yourself and why you decided to join the Learn Look Locate team of 21, soon to be 22 medical advisors?
Thanks, Cynthia. I'm happy to be here and happy to help out. My name is Dr. Stacy Tanouye. I'm a board certified OBGYN physician in private practice in Jacksonville, Florida. I've been in practice now for over 13 years. I strongly feel that as gynecologists, we're at the forefront of these breast cancer diagnoses because we're the ones, along with our primary care colleagues, that are in charge of screening and in charge of those guidelines and in charge of empowering our patients to follow that and also to be proactive in their own care. And so it really kind of all starts with us and our teaching to help implement and really translate the importance of all of that to our patients so they feel empowered enough to go out and find the good information and to advocate for themselves. So I do truly feel that between us and the primary care doctors, we're at the forefront of all of the beginnings of this.
Yes. And that is truly one of the reasons why I started this, because I think the lack of education and us working together will hopefully bridge that gap on so many topics. So I want to share with our audience today that I'm so excited to talk about many different topics that I feel need to be discussed kind of in a patient-friendly way, such as the rare types of breast cancer that need to be talked about, educated, and understood, genetic testing, breast density, so much more. But I want to dive in first on one of my passions is breast density. Do you feel that the gynecologists are really spending enough time with people who, especially whether they have a genetic risk or they don't? Because as we know, 85% of us, and that includes me, have no family history of breast cancer. And so by getting letters in the mail that say, you have extremely dense breasts, and just going on my merry way with 2D mammography with no education or awareness, yet a walnut-sized tumor growing inside me for possibly 5 years in a blind spot. So all these strikes, but no education. And so out of respect to the gynecologists, I want to say, I know you guys are very busy, but let's add to that, I never even did a self breast check because nobody really even showed me, and I didn't even know what I'd be looking for anyway. So
Right.
how do we change this, and what are your thoughts about this? Do you feel that gynecologists are really talking about this?
This is such a complex and difficult topic because really up until recently, I don't think we've had a whole lot of guidelines of how to counsel patients and
That's
where
right.
to go with patients. Because it was literally just recently that the NCCN guidelines just updated. It was this year. So 2025 was the first year that they updated their guidelines and made more firm recommendations. So up until this year, we didn't even have good recommendations of if you have this, then you should do this. Now it is required for breast reports to report the density
That's
category.
right. That's
So
right.
now that has to be standardized and universalized. The breast density categories C and D, C is heterogeneously dense and D is extremely dense,
Right.
finally have some guidelines of what we should do. Category C, the heterogeneously dense, are still a little loosey-goosey. In fact, the guidelines are still consider additional screening, consider this. And so that puts us in a hard position of how we counsel patients because those guidelines still say consider. That's a really wishy-washy area, particularly for insurance coverage, and that's where it gets really difficult. So,
Interesting.
yes, as GYNs, we need to be talking about breast density more. I wish we had more time in our clinics to be able to do this, but we do have to start bringing this up. And it's hard because it's a bigger conversation than what I can often handle in 15 minutes in my annual visits. but often
Mm,
something that I kind of have to broach. And if I'm broaching that topic and opening up a can of worms that's going to last me more than 15 minutes, I mean, I do that all the time. And so if you're a patient of mine, you know that I'm going to routinely run 15 to 30 minutes behind because I'm trying so hard to reach these topics in a time sensitive manner and in a manner that people understand, but it's hard. And
mhm.
so, again, to back up, category C, heterogeneously dense, still the guidelines are still consider additional screening, consider additional MRI screening. The intervals at which you do that are not necessarily set in stone. Consider doing this every so often. And when the guidelines say consider and it's not a strong recommendation, insurance never ever wants to cover it.
That's exactly.
That's why it's so hard because then patients are left with this decision of what do I do with that? Do I
Mm,
need to shell out $1,000 to $2,000 to get an MRI every single year because I have heterogeneously dense breasts? Is it worth it? Is it worth the money? Is it worth this? And that is really hard to process through with patients, both as a clinician and for them to be in that situation of how do I make
side.
that decision? It's really a difficult spot for patients to be in, and it's an equally difficult spot for me to be in my counseling. For extremely dense, for that category D patient, it's become a little clear cut. I think this is the first year that the NCCN guidelines actually say for heterogeneously dense patients, which again is only about 10% of our patients. Most of our patients are lying in that category C, the heterogeneously dense. For the category D, the extremely dense, the guidelines are finally saying recommend MRI, additional screening. MRI
Mhm.
is the preferred modality. We recommend additional screening. And so I'm hoping that insurance is going to come through and start covering things more. The other issue is just insurance plans in general, because even when an MRI is covered, it's still going to be subject to deductibles and the plan and where we stand. So someone could still be left with a high out-of-pocket cost, which is also just a horrible place to be in. I hope as we evolve that more and more imaging centers are going to be adopting these fast breast MRIs, the quicker screenings, and start offering them at their kind of out-of-pocket flat fee rates because that's been really helpful for at least my patients. I have
Mm.
one imaging center in town that will offer a flat out-of-pocket, not going through insurance, fast
Wow.
breast MRI for $400. And in the realm of MRIs, that's considered cheap, but we all know $400 is still not very cheap.
That's right.
Again, it's just a hard place to be in, both from the counseling aspect, the recommendation aspect, and then the insurance cover aspect, because all of that goes into the decision making of is this patient going to do an MRI? It's a very difficult place to be in, and I do wish we would all talk about this more. And we're getting more and more education of what those guidelines are, why they're changing, the numbers behind it. We're starting to learn more about it in our continuing medical education modules and everything. And so I really hope that GYNs are paying particular attention to this and then are translating that into realistic recommendations for our patients.
Wow. This really helps for me as someone who went through this to understand what you guys are up against. So I'm sure many people watching, I really appreciate this. It's extremely helpful. So that helps us understand the disconnect because as you can imagine, I was quite angry. And when I look back, it's hard to process. I want to ask you, do you think people like myself really understand what category C and D actually mean? Because I just launched a whole page on breast density, not only to explain in a beautiful way what A, B, C, and D stand for, and then the BIRADS, really breaking this down. What is your BIRADS category? What do they all mean? This is all so Greek. And so, if it weren't for me sharing with my friends, none of us understand the importance of breast density. It's like this hidden known fact. And unfortunately, someone like Nancy Capello, who passed away, carried that torch for her organization, Are You Dense? Because same situation, it's happening to too many. And I never felt sick, even though I had a walnut sized
Right.
tumor. So there's a lot here to unravel. I'm just curious, do you think your patients understand these categories?
I think it's hard for anyone to understand these categories. It's not necessarily hard to understand the categories, it's hard to understand what they mean.
Yeah.
How do I translate into what that means for me in particular
Yeah.
is
What to
probably
do.
the most difficult thing. It is challenging because we know that over the age of 40, mammogram screening should start at the age of 40 for all average risk women. But over the age of 40, half of them are going to have a category C or D mammogram.
That's
Half.
so
And like I said, 10% of that is that category D, that extremely dense, and 40% of that is heterogeneously dense. So 40% of my patients are still lying in this wishy-washy, we should consider this. And that's a hard back and forth conversation of weighing personal risk benefit, personal socioeconomic, and access availability, and then even that 10% with the extremely dense, it's still a similar conversation. Even though I say this is what the guidelines say, they say we should be adding preferably an MRI to this. Whether or not that patient has access to that MRI, both financially and physically, it is a whole nother question. And
yes.
that's where the really unfortunate part comes in. And that's where things always lag. Like medical information and knowledge, lags in getting the recommendation out. Then it lags in the clinicians learning about those recommendations to then
Yes.
help disseminate and our patients understand. And then the insurance lags behind that. So it's all of these kind of delays in how that care comes about and how that translate for outcomes for our patients. And it's just a detriment of how our healthcare system is set up these days.
Yeah.
We all want more time, more access to everything. And
Yes.
that's one of the more challenging things to come across is I can talk to my patients up and down about the recommendations, but whether or not they can actually follow through feasibly with those recommendations because of all these barriers is a whole nother ball game.
Key word you said is time,
Mhm.
because, I believe a lot of people are just not recognizing the extreme importance of taking action and advocating for themselves. Because listening to you, that is the key thing here. You have to advocate. If you see breast density, you need to ask what your density is. And then you need to ask for supplemental screening. But hearing you say that's a really hard fine line. Do you choose between the $1,000 MRI or your rent or whatever? There's a lot here.
Right.
So,
And even now that these new guidelines are getting updated and we're getting a little bit more firm in our recommendations, now I'm going to have to go and backtrack to all the patients that I counseled 1 and 2 and 3 years ago and say, okay, these are updated. Now, does that make your decision different of how we proceed and what we do? Because this guideline, this extremely dense category now firmly says we recommend additional screening. And that's just another conversation, another layer of helping patients make those decisions for themselves.
and
It's
this,
hard.
this is also a global issue. I've had some conversations even in India with a radiologist saying that some of the ladies don't even want to get a mammogram because they don't want to know anything. And
Mhm.
so even if you know somebody who's getting that note that says extremely dense breast, but normal, 'cause that's what I got, they're fine with that. So I was fine with that. I didn't know better. So we could
Yeah.
go on for hours. There's so much I want to talk to you about. Just a touch on artificial intelligence in
Mm.
mammography,
Yeah.
and making sure that whether your clinic or this clinic, pushing people to know the advances. Can you talk about that a little bit?
That idea is very, very new. I was just literally at the Menopause Society national meeting a week and a half ago, and this topic was brought up that there are now new studies being done to simplify even the MRI portion of things and simplify kind of the mammogram portion of things by adding in AI. So, how can we simplify and improve access for MRI? And maybe not everyone needs to get vascular based imaging, so MRI with gadolinium contrast or
Mm,
mammography contrast enhanced. Maybe
yes.
instead of that aspect, we can use AI to come in and help us with some of that detection. And they've done studies on this, and it's quite impressive. They've done
Yes.
studies where they've looked at MRI plus contrast versus MRI without contrast plus AI.
And?
and it's matching up really
Wow,
closely. So
that's wonderful.
hopefully in the future, we can
Okay.
utilize some of these AI technologies to decrease some of the contrast exposure, whether that's gadolinium or ionized based contrast, and hopefully that'll help access cost and exposure on all of those things. So AI is going to be a new and emerging technology that I hopefully is going to help us improve
That's
our detection.
yes, that's really
Um,
exciting.
yeah, because there is concern about exposure of gadolinium over time, and we don't
Yes.
quite know those long-term effects, but some of
Yes.
that discussion is happening.
Yes. Something I'm going to just ease into for a second here is the breast biopsy experience. Does that fall under you, I would say?
Usually not. Usually that's the radiologist. I'm
Okay.
just orderer of a
Okay.
breast biopsy. In my realm, I am not involved in the actual process. And to my benefit, all the radiologists surrounding me are the ones who own their biopsies as well
I
as their
see.
results. So they're all the ones conferring those
And
results
take
and
it from there.
taking it from there. We get the results after the patient has already learned about them. And then I'm the one who's facilitating all of the referrals and next steps after that. But
Sure. Okay.
oftentimes, by the time I get the biopsy result, the patient is already in the process of learning the results before I even see it. So, which is
Yeah.
helpful for the patient because they don't have to wait for the fax to go through and then the message to
Yes.
me. It's already
Yes.
been done from the radiologist
I
standpoint. And that
see.
varies region to region of how
Okay.
that process works and how patients get those results.
I bring that up because I do talk about that a lot on just the emotional impact
Mhm.
of what a breast biopsy brings to somebody and how emotionally devastating it can be, whether it's cancer or not. I just need to address that. This is the beginning of how hard it is emotionally, the roller coaster, the waiting, the uncertainty. So again, we have a whole page on breast biopsy with Dr. Stacy Smith Foley to educate people on the different types and what it all actually means. So
Yeah.
just part of the journey if you're going through a possible diagnosis.
And I think even before that, the process of getting the callback of you need more
Oh,
imaging
yes, yes,
is the same sort of feeling, the
yes,
anxiety and the
yes.
anticipation. And, I try to tell my patients, even especially my younger patients who are starting to
Yes.
get their first mammograms, like, okay, your callback rate for a first mammogram at a younger age is high.
Okay.
Just to let you know that in general, there's like a 10% callback rate of I need more imaging. And only a
Okay.
small percentage of that is going to need a biopsy, and only a smaller percentage of that is going to be a positive biopsy. And for younger patients and for first time sort of mammographic screening, those numbers are even higher, the callback, because there's no comparison. And so there's
Yes.
a lot of patients out there who are getting that anxiety of the callback for the need for more imaging and not understanding that
Yeah.
process.
Yeah.
Yeah.
Thank you for
So it even
understanding.
starts from there. And then obviously it escalates as you go down the route. Hard
Awful.
place to be in.
It's really awful. I think knowledge calmed me down and still does. That's why, I kind of started this. I wanted to know more. I think just
Yeah.
the not knowing is very anxiety ridden. I want to talk about two different things. Young people and breast cancer on the rise, and also different rare forms of breast cancer. So I'm going to talk about the young people in a second because it's a big passion part of what I'm doing. I have recently launched a page on Paget's disease.
Mhm.
I've also interviewed an incredible survivor named Katrina on her journey with inflammatory. There's also lobular. These are the types of breast cancers that are very hard. Even though I had a hard tumor, I didn't know I had it. But Paget's disease and inflammatory, do you feel that the gynecologists are well trained and educated to understand and diagnose, or at least give the patients the awareness of what these types of rare forms of breast cancer are? Because I've had so many come to me, and they're all over the website, that have been misdiagnosed for possibly 2 years, especially Paget's that is getting misdiagnosed as eczema. So
Yeah.
please, the gynecologist, I want to ask, you probably know this, Dr. Stacy, but oh my goodness, if other gynos are seeing this, they need to know these rare forms.
There's an understanding that these rare forms exist. I have a very special perspective on kind of zebra diagnoses, if you will, these kind of rare diagnoses, because I've had a zebra diagnosis myself, not related to the breast, that was missed for many years. And my feeling as a clinician is a little more complex because I've been on both sides of that zebra diagnosis. I have been the one struggling and then not being and being missed, but I've also been on the other side of being the clinician who's trying to catch these zebras, but also not trying to give a false positive rate or fear of that. And I think it's a really hard balance because when you have a rare disease, we can know that they exist and understand they exist and have
Right.
it on our radar. But when it's so rare and you can go, I'm, 13 years into my career plus 4+ years of training. So I am 17 to 18 years plus into my exposure to all of this. The number of cases of I have seen, I can count on one hand. And so that is where some lack of experience, just because it's a rare disease, is an issue. It makes it more cloudy for us to be able to recognize it. So it is a harder diagnosis as clinicians for
Mm,
us to make. But I also agree that yes, we need to keep that in our differential diagnosis, that we need to be more aware of kind of some of the simple and subtle changes so we can pick up on that. But
please,
that
I'm
does become
begging.
a harder process the less we see it or if we've never seen it at all. And so, in my experience as a zebra sort of diagnosis, is I know this is different for every single patient. So, I will speak for myself for this. I, in retrospect, don't necessarily feel that I was missed in a harmful way. I feel that my zebra diagnosis just wasn't found, which is just a different perspective to take. And it kind of was a perspective that gave me a little bit of solace. It's hard to miss a rare diagnosis that's a needle in a haystack. You just didn't find it. And those are two just different ways of me as a clinician reconciling those challenges as a clinician of not being able to find something versus straight out missing something. If I miss something common, that is a much more egregious thing if I just can't find something that's rare that I'm looking for. We're out there looking and doing all of our due diligence and following our recommendations on all of this and trying so hard to find something. If I can't find it, that becomes a hard thing for both of us. But to me, that's not as, I should say, egregious as missing something that is common. And that's a
So,
hard place to be in as a
yeah.
clinician and as a patient. So, yes, we need more education. We need to understand what we need to look for. We need to
Yes.
continue to talk about it and to teach about it. But as a clinician, I've also given a lot of clinicians a lot more grace since my own.
Well, the reason why I'm so passionate about this, the Paget's disease page on Learn Look Locate, medically vetted by Dr. Yara Robertson, breast surgical oncologist, and powered by 4 survivors, one in Australia who was dismissed by 20 doctors who's
Mhm.
metastatic. All of them, and I'm going to cry, 2 years dismissed. They don't know what this Paget's disease is, and it's getting confused with eczema. And I will tell you on social media, people are now reaching out to me because I'm talking about it, and they're like, oh my God, I think I have Paget's. And, it just needs to be, whether, even though it's I forgot the percentage, maybe 1 to 4%, it is out there.
Yeah.
And inflammatory is another one, and that is so aggressive. And Dr. Allison D. Pasquale, I did an interview with her and 2 inflammatory young in the 30s. Um,
And I think one of the hardest things there, one of the key things you said there is people are being dismissed. That is the problem. It's
yes,
not always the clinician not understanding what we're finding or what we're looking for. It's the clinician being dismissive of something. So if
yes,
I don't maybe fully understand or know or am unsure, my role as a clinician is not to dismiss people, it's to raise my hand and ask for help and to
there you
continue.
go.
So
Thank
when
you.
I don't understand or don't know something or can't figure something out, I need to start punting. I need to bring into a specialist. I need to bring in a referral. I need to ask for
Yes,
more help. So
yes,
some of that is not necessarily an education aspect on a clinician's part. It is
Okay.
a ego aspect of saying, I need to ask for more help because I can't
Yeah,
figure this out. So I need to find someone who
that's
can.
great.
I need
Yeah.
to refer to a dermatologist. I need to
Yeah.
get another set of images. I
Yeah.
need to bring in another specialist to help me
Yeah.
find what I am obviously missing. And I think
Yeah.
that is one of the key things of being evaluated and worked up because you can
Okay.
be evaluated up and down. And if I'm still not finding it, that
Yeah.
we're working towards that. But to
Okay.
have a patient that feels, like you said, dismissed is a total separate issue in my
Yes.
mind. That is a
Yes.
completely unacceptable issue. That is
Okay.
not just a lack of education, that's a lack of humility on our aspect and our side of things to say,
Mm.
I don't know what this is, but I have to figure it out and I have to find someone who can help me do that.
Awesome.
That's a
Yeah.
separate issue.
Okay.
And that
So
is a far more egregious issue.
yeah. Yeah.
That's
So
not a
this
lack
is
of education, that is a lack of humility.
Well, you are uncovering a lot of great things that I think people will feel really comfortable understanding and knowing. So, busy or not, you don't know the clinician, help us out and do not dismiss these women. I mean,
Yeah.
it just breaks my heart. And
Thanks for bringing that up because I think that also shapes in how I feel about those kind of zebra diagnoses. Because
yes,
someone who feels like they weren't necessarily dismissed, like myself, I feel
yes,
like people did their due diligence in working up some things. And I feel like there was little things that were missed that could have made a difference. But at
sure.
no point did I feel like someone was unwilling to order the next test or who was
Oh,
unwilling to try for me. And that shaped how I felt a whole lot. Now, when you flip it on the other side and when you have a patient who feels like they're not being heard, who feels like they're not being responded to or
that's right.
listened to, that's a totally separate, even more egregious issue than just the education on our part as a clinician.
Yeah, and I will share with you one of my dear friends who's on the Paget's disease page. She's in the healthcare industry and she kept saying something is not right. She
Yeah,
pushed for the biopsy. And
yeah,
that is something that, not many of us are going to say, hey, can you biopsy this area? Ouch. But it is rare and doesn't show up as a lump and it shows up as eczema and then it goes away and everyone thinks it's fine. So I want to share with everyone, I have a chart and this is all medically vetted by Dr. Robertson, eczema, Paget's disease, key
yeah.
features, and it's really great, really breaks it down. So, and then there's a whole bunch of questions to ask your doctor. So, what I'm trying to do here at Learn Look Locate also is empower people to bring these questions forward to help. I mean, to bridge that gap based on even just the knowledge I'm learning from you, you might not know, but if they ask the right questions. So speaking of that, I don't want to take up all your time. I have so many questions, but young women in breast cancer, it is on the rise. And every day, as you probably see it, we get on social media, they're stage two, a year later, they're metastatic. I want to address that issue, but also in talking about genetic testing as part
Mhm.
of this conversation. I myself have a family history of cancer. I was never genetic tested until after I heard the words you have breast cancer in a whirlwind of genetic testing. So again, another bottleneck of lack of information and why are the gynecologists not sitting down and talking about genetic testing? And then after that, we can talk about young women and what's going on with their diagnosis in the 20s and 30s. Sorry.
Yeah, I think when it comes to that sort of genetic screening, again, these new iteration of guidelines say that we should be screening people for their genetic risk by the age of 25. So not testing people, we should be screening their risk and seeing where
Interesting. At
they're at.
25.
So at age 25, we should be effectively reviewing a family history and reviewing personal risk factors to understand their approximate lifetime risk of breast cancer. There are some companies out there who have made it really easy, who have just a basic family history and personal history questionnaire that if you hit these points, then that is a patient that should be considering genetic testing, because not everyone needs genetic testing, but there are certainly people who would screen into that pool, and that we should be starting that screening for who needs that genetic testing around age 25.
How do they do that? So I'll give you an example. I have a 25-year-old daughter.
Mhm.
So I had breast cancer. My father had lung cancer. My grandfather had colon cancer. Should she be genetic tested? And if so, how? How do you do this?
Yeah, there's different criterias for kind of the different cancers. For breast cancer, there's certain, red flags that come up. Do you have a first degree relative who was diagnosed with breast cancer under the age of 50? One first degree relative under the age of 50, we should talk about genetic testing. Do you have two second degree relatives with a breast cancer diagnosis over the age of 50? Though, all these little kind of red flags come up, and those are the factors that will factor into whether or not we're talking about genetic testing. Now, we're getting a lot more information about clusters, right? These clusters of cancers, and it's not just breast, that there are some clusters of cancers of breast, pancreatic, bladder, renal, these kind of cluster sorts of things. And so some of that, it has to be popping up on our questionnaires. And this is all patient intake forms that we have patients fill out of their history that goes into our EMRs, our electronic medical records. And it's becoming easier to screen that because a lot of our electronic medical records should be having some of these red flag screeners automatically in the system. So it pops up for the screen of this is what they entered for their family history. These should be screening tool questionnaires that we're doing on patient intake in the outpatient setting.
This is where I get really confused. How easily can someone get this genetic testing? And the questionnaire is like, I never got a questionnaire until I moved. So, which was recently. So, my whole life, I've never
Um,
been asked any genetic background. So, do all gynecologists do this? Do you know? Is it
I
now?
don't know other people's practices, but as long as I've practiced, we've always taken a family history. And at the beginnings of kind of early on genetic testing, a number of years ago, it used to be the genetic testing companies. I know for a long time, Myriad had its own form. We used Myriad's form for a decade. It was a paper form that people just checked off. Do you have a first degree relative who's been diagnosed with a breast cancer under the age of 50? Check.
Do you
And
still
then
use their form?
I think we don't use their particular form anymore because now ours is kind of all electronic based. But yeah, we used Myriad's form for a long time, a really.
Once you get that assessment, is it the gynecologist's role to continue to push? I mean, let's just say someone has the BRCA gene, but they don't know it, and they take the assessment. How is the gynecologist's role in that, for instance? I know there's obviously the genetic counselor at the forefront of all of this. So
Yeah,
what does that mean to, I don't even know what BRCA means, for instance. Like, what do
right.
I do? Right?
No, it is our role to screen and to test, and that should be something we should take as routine on our annual GYN exams. And
Okay.
so, as long as I've been in practice, we've always had access to genetic testing, and we screen and test patients frequently. I
Okay.
wish that was the case for access in all locations, but I know that's not the case. But
Yes.
it's not hard to do that. Now, again, the other hard part is when someone then tells me, well, is my insurance going to cover this? Because that might make the difference of if I test or if I don't test. Now
Yes.
that's the whole other stupid part of our healthcare system is I don't know. I don't know what
Yeah.
your insurance is going to do with
Yes.
this.
Yes.
A lot of the companies right now have it set up whereas if insurance is not covered it or if the cost is going to be over a certain rate, then again, they have a flat out-of-pocket fee. So
Okay.
that's kind of how we've usually tried to approach it with people of we use, XYZ specific company.
Right, right,
They
right,
will
right.
have a flat, $250 or $300 flat fee. So if your insurance doesn't cover it, that should be the max that you should pay.
Okay.
So that has kind of helped a little bit, but still, that's a hard conversation because
Yeah.
I can't tell people what that's going to cost them
Yeah. You're in a
because
tough spot for
everyone is
sure.
in a completely different insurance plan. Different
Yeah.
insurances are going to follow different risk models. So for
Right.
one insurance, when they cover it because this person has this type of family
Yeah.
history, but that same family history, this other insurance company is not going to cover that. And so again, our healthcare system is broken. I wish I
Yes.
could just tell people that, like, you have this history, your insurance is going to cover this testing, and that's just not
Yeah.
true.
Yeah.
And that puts burden on the patient for calling and asking their insurance company, well, will this be covered? And the insurance companies are just not set up to understand the factors that go in the family history and genetic
Sure.
risk factors that go into coverage. So they often can't even answer that in a clear way. And so people are getting roundabout answers from every
And Dr.
source. And it's just it's
So hard.
stupid.
So
And I
hard.
wish it was more simple. I wish
Yeah.
it was easier. And I don't have a good answer of how to make it
No,
easier.
I will tell you, Dr. Stacy, after working with my senior medical advisor, Dr. Rosen, genetic testing could be so life-saving. I've lost too many people in my 5 years of doing this that if they had known they had the BRCA gene. I interviewed Dr. Allison DiPasquale, one of my medical advisors, on the genetic testing page. Take control of your genes. This is the one area in the breast cancer preventative that we can be smart about. And I'm
Right.
angry that I never knew. I know now, but it's also like when you're diagnosed and you have all this information, you can talk all day long and say to people, are you genetic tested? A lot of people don't want to be hit over the head with this, but if they
Right.
realize the power, and that leads me to share how many I see on social media that are BRCA positive, stage 2, and now metastatic. What is going on in your mind when you see the 20 and 30-year-olds? And thank goodness they're doing self breast checks, because I understand there are some organizations that don't believe that is a way to determine if you have breast cancer. My head's spinning. Like, how else are these young women supposed to know? And thank goodness they are doing them, because I didn't. And it's just the disconnect is so strong. So one of the reasons why I do learn, look, locate the way I do it is to wake people up, but also attract the younger audience in addition to the older audience to bring them in to learn in a way that's calming and beautiful. And these young women, I mean, what are your thoughts, Dr. Stacy? I mean, it just breaks my heart. They're not even thinking about this.
It's hard because I'm not sure any of the major organizations actually firmly recommend self breast exams anymore. I think nearly all of them, if not all of them, are recommending what we call breast self awareness, which is just the idea of not having a firm interval of doing breast self exams. You know, it used to be once a month, you should do a self breast exam, right? That was the recommendation. And I think that has very much evolved into what we consider breast awareness, that you should be aware of your breasts and breast tissue. You should be aware of changes, but then how you go about that is an individualized process. Whereas some people do well with that because, again, it's an individualized health measure, so they can do with it what they will. But on the other hand of things, it makes things wishy-washy and it doesn't give us a firm
That's right.
recommendation or interval.
Yes.
And so
Yes.
it can kind of go both ways. It can be both empowering, but it can also be confusing.
Thank you for that, for
And
sure.
yeah, and it's hard. So whenever I have patients who have questions about that, I start clinical breast exams on annual exams. The current guidelines say to start by age 25. I'm typically starting somewhere between 18 and 21 in the clinic on
Wow.
self-breast exams. And then when I have patients who have questions or whatever, then I'm showing them how I'm doing my breast exams and how I'm specifically looking for things, which
Can you
is
show
often,
us?
yeah, it's different than a lot of the recommendations are online when you see the pictures and the videos. A lot of
Yeah.
people talk about kind of the circle pressure and varying
Yeah.
pressures and getting deeper. For me, I don't like that method because I feel like, especially for our young patients, with most patients are going to have dense breast tissue. Natural, normal breast tissue is naturally lumpy and bumpy. And so when you're really just starting that breast awareness, it's hard to figure out
Yeah, I can
what is
imagine.
normal lumpy bumpy in breast tissue and what
Yeah.
is not normal lumpy bumpy. And to me personally, as a clinician and as a woman with breasts, that the circles just never resonated. It even in my learning and training, it made it confusing. So I teach patients the push and drag method. And This is the push and drag method. I have several videos on my social media of how to do this. I think I missed this year, but generally every October I'm reposting my same
Yeah.
video of how I
Yeah.
teach it. But essentially, I'm teaching patients do it laying down, doing standing up, and vary that a little bit. But the basics of it is you want to start, think of your breast like a circle. Start at the outside of the circle and obviously start in the armpit, but start on the outside, push down and drag towards the middle, towards the nipple. And then do that in a circle all around, full circumference. So push and drag,
Laying
push,
down or
drag.
sitting up?
Both. Do it both. So maybe one month you do it sitting up, maybe the next
Okay.
month you're doing it laying down, just so you can get an idea, because breast tissue moves with how we're positioned.
Okay. This
You
is
probably
really
know
helpful.
people can, if you have a lump, you can feel it laying down, and if you're sitting up, you can't, or vice versa. So you
Okay.
kind of want to mix and match and do a little bit of both of that. But the push and the pull and the drag, normal, bumpy, lumpy breast tissue will move and blend with that pushing and pulling. Okay, so as you push and move, normal, lumpy, bumpy breast tissue will smooth out, will move all together, and it'll kind of blend well.
Okay. Okay.
Abnormal in general will not. Abnormal, when you push and pull towards the middle, you'll hit something and you'll have to go over it. That little something won't blend, won't move with the rest of the breast. You'll hit it like a little pebble and you'll have to skip over it like a rock. And to me, that's the easiest way as both a clinician and as a patient to really differentiate normal versus abnormal. Because what I hear from patients in the clinic all the time is, I don't know what I'm feeling. It all feels like a lump to me, like I'm feeling a million lumps in there. And so, how do I know if that is normal lump or not normal lump?
Yeah.
And that, when I'm explaining it and when I'm doing it, is the easiest by far way for someone personally to examine themselves and be like, that blends all together. That's normal lumpiness versus that is not. I'm hitting something, or that feels like it's sticking out when I'm doing that. And then that is not normal. And then you come see me and we'll go forward with all of that. In my mind, that's how I was taught in residency by our
Interesting.
breast health, specific
Okay.
breast health clinic. And that is how I teach my patients to do it too.
So, on a personal note, maybe TMI, but my walnut-sized tumor was hidden behind this area. So,
Mhm.
even from the pushing and the dragging, would you even suggest a little pinching? Because,
As when I do it, I do the pinching. I pinch up and down and side to side, kind of underneath the nipple.
okay,
I don't always specifically tell patients to do that because really, if they're pushing and pulling, they should be going all the way across and at different angles, and so could potentially hit that, but that is harder to catch.
yeah, yeah,
So
blind.
I tell people when I do it in the office, I pinch up and down and side to side. So I'm looking for that once a year, but
That's
yeah.
great. I want to share with anyone listening that completely painless, never knew it even existed. So it is a big aha moment. And even when I got diagnosed and I was going through the whole breast cancer roller coaster whirlwind, I work out a lot and I call the nurse navigator. I'm like, am I going to hurt the tumor? Like, we're so dumb and we're so clueless. No, it's okay. Is it growing every day? And just all the confusion. All of a sudden, there's this foreign thing inside me that I never knew. So
Right.
I just want people to aware it can be very painless for many of us. And you can just keep on keeping on. You're living your
Correct.
life.
I mean,
So,
breast cancer is painless in the vast majority of people. Most people are
so
not going to
important.
have breast pain with their cancer. So that's one of my teaching points as well. If someone comes to me and saying, I'm having pain or discomfort, the vast majority of the time that's benign. That is not breast cancer.
Isn't that
Not
interesting?
always, there's always an exception to the rule,
Yeah,
but the vast majority of the time, breast cancer is not painful.
go figure. Well,
Yeah.
you have been so generous with your time. I literally could stay on here for another hour, but I do want to be respectful. Do you have any closing? Oh, I have one other, the last one.
Yeah.
Oophorectomy. Oophorectomy.
Yes.
I almost
Yes.
forgot. I want to share with everyone that I was not in menopause at 52 when I was diagnosed.
Yeah.
One of the reasons why I wanted so badly to have a gynecologist be part of Learn Look Locate, not
Mhm.
only for all this great information, is because my gynecologist recommended the idea of getting an oophorectomy because I was estrogen positive. I had already didn't need these ovaries anymore. And so when I learned that it could take my risk of recurrence down 50%, I said, sign me up. And I do want to share with the audience, it was an in and out, and I feel great. Now, I do have another friend who did it, a survivor, and didn't feel so great. So I think it's very personalized.
Mhm.
But for me, the comfort of knowing that I did it, the risk of ovarian cancer is not there anymore, which is kind of nice, but it really wasn't that bad. And I post about this, and people don't know what it is. And my gynecologist actually did the surgery. So I did this after my double mastectomy, radiation, and all of that. And I'm really glad I did. So the gynecologist, do they play a role in this? Can you talk about oophorectomies and what exactly it is?
Yeah, so there's an idea of what we call risk reducing salpingo-oophorectomy to reduce risk of breast cancer. For example, in your case, risk of recurrence of breast
Yes.
cancer. We have some pretty solid data to suggest that specifically our BRCA1 and 2 previvors, so our patients who know they carry one of these two genes, but who have not yet had a diagnosis of breast cancer, that doing a bilateral salpingo-oophorectomy or removing both tubes and ovaries can reduce breast cancer risk by up to 68%. So
Wow.
in our genetic carriers, our highest risk category people, salpingo-oophorectomy can reduce that risk significantly and more significantly than medical ovarian suppression. The data for people who are not genetic carriers who have had a breast cancer pre-menopausally, that risk reduction is there, but it's not as dramatic as our
Okay.
BRCA1 and 2 carriers. And it is similar risk reduction to medical ovarian suppression. So whether that's with a GnRH agonist like a depolupron or something similar, or with use of tamoxifen and other
Yes.
aromatase inhibitor drugs as well. Salpingo-oophorectomy is similar to those medications in ovarian suppression for risk reduction in our
Okay.
premenopausal estrogen receptor, hormone receptor positive patients. The downsides of that, which also have to be talked about, is well, medical suppression of ovarian function is temporary, right? So it's temporary. And after, if we have a very young patient, after you go through treatment and surgery and potentially positive plus or minus chemotherapy, after that whole process, there's a chance that you may not be in menopause anymore. And now we may be done with our medical suppression of ovarian function. And maybe you can still have that natural function that could potentially be beneficial in the long term for overall health. So we're talking about cardiac health, bone health, brain health, and long-term
Mm,
survival rates. Whereas on the other hand, surgical menopause or removal of the ovaries pre-menopause
permanent.
is a permanent
Yeah.
state. That's
Yes.
permanently removing those hormones, which can be a good and it can be a bad thing in certain aspects of things. So I think people also need to understand what the meaning of surgical menopause is and what the potential risks of surgical menopause is in relation to their breast cancer risk.
Okay.
Surgical menopause is also not for the faint of heart. It is a
Hear about
hard,
it.
hard place to be in for many
Yes.
people. And for some people, that may be very much well worth it. And for some people, it may not be. And
Yes.
hopefully, fingers crossed, with our new non-hormonal medications on the rise for our vasomotor symptoms that are non-hormone based, hopefully that's going to be a more accessible and acceptable option for a lot of people because we're getting more medications in the non-hormonal realm that can now treat these hot flashes, night sweats, and all of the things that come with
Yes.
surgical menopause.
That's so
So
right.
hopefully that will help mitigate some of that permanence of that because surgical menopause is hard. And it's
Yeah,
not something that we need to ignore just for the sake of risk reducing breast cancer. We need
right.
to address all of it because it's all can be equally important.
Yeah, and I think it's just important to bring up the role of gynecologists for me, that played in this decision. It's not like the cancer center brought this up. So I
Mhm.
sort of sought this out on my own, as I've done a lot as far as information. It's all
Yeah.
scattered and very
Now, I'll
different.
add too, at the Menopause Society just last week, there was a big talk about this by one of my colleagues, and she brought up the research and the data to support that in pre-vivors, so women who
Yes.
have not had a diagnosis, who are known genetic carriers of BRCA1 or 2, the most beneficial situation is to actually remove tubes, ovaries, and potentially the uterus as well, simply because in pre-vivors, you can still use hormone therapy. You can still use menopausal hormone therapy and not affect risk. And estrogen only hormone therapy in pre-vivors after removal of ovaries can actually decrease overall breast cancer risk. And
Completely.
so there might be a big role not just for removing tubes and ovaries in BRCA1 and 2 previvors, but removing the uterus as well. So then when we concentrate on hormone therapy, menopausal hormone therapy, we're doing estrogen only hormone therapy, which may be the safer and actually further risk reducing option.
This is fantastic.
That was a really
Aha moment.
interesting point that was talked about at the
Yeah,
Menopause Society
yeah,
last week. That is a consideration. And in the past, we used to say, no, the hysterectomy was a bigger surgery with more risk and that sort of thing than just the tubes and ovaries, because it is. And so that has to be balanced. But the benefit of also removing the uterus is when we do our hormone therapy in our previvors, we can do estrogen by itself. And estrogen by itself, we don't think increases breast cancer risk. It might even decrease breast cancer risk overall. And it can actually prolong and
wow.
decrease long-term mortality as well. So there are lots of new data on the horizon, so many more things to consider than we ever have before. It's all very complex because there is
Yes,
risk and benefit to all of it. Not every patient's going to fit in a cookie cutter of one direction.
that's
And so
right.
all of this really needs to be individualized patient to
Yeah.
patient.
But it's just so great to hear you speak about it because I mean this could be life-saving information for people to really digest and understand. And it's just not out there. So
Mhm.
having these conversations, I think, are just so critical. And you've been amazing, Dr. Stacy. I mean, this is really, worth the wait. And trying to get to Dr. Stacy isn't easy because she really is advocating quite a bit. And we really appreciate that. We need you. And I'm so grateful to have you be part of Learn, Look, Locate. Gosh, this is going to be so helpful. And I just appreciate the candid honesty on the kind of the cracks that are happening between the patient and the gynecologist, and just really helping us to work through that. And the more we can openly talk about it and get this out there on social media and here on your dedicated page, that people can really just sit and listen because I needed this. I was angry and frustrated. The goal is to get to people before they hear the diagnosis as well. So they're empowered,
Yeah.
really get people to understand their breast health through the power of your words and the gynecologist. So hopefully gynecologists will watch this. And do you have any closing thoughts before we finish here?
I think just everything that we've talked about, we as GYNs and our primary care colleagues, we're at the forefront of screening, at detection, and like we touched on before, all of that has to come with an ounce of humility. Like we need to listen to our patients, we need to act as adjacent advocates to our patients, not only empowering them to advocate for themselves, but also doing the advocacy for them at times. And if we feel that we are not getting answers or that we don't know something, we have to have the humility to ask for help of more, other experts, of second opinions. I tell my patients all the time, I am never the end all be all of your opinion. If you need a second opinion, even from one of my colleagues, please, by all means, do it.
Wow, that's
And we should
great.
be encouraging that because that is what helps people feel empowered
Yeah.
and not dismissed. And I think a lot of the anger and resentment is from that and
Yes.
not always from our lack of education from a clinician standpoint. Yes, that can be an issue at some
Yeah.
times, but I think the much bigger issue is just the dismissal,
Oh, so
feeling
many
of
people.
dismissal.
Yeah. Yeah. That's
Yeah.
so true. And I think people are going to really appreciate those words.
I think I have a little visitor here.
Hi
Oh,
there.
who
What do
got
you want
home
to
from
say?
school?
Oh, I should let you go. Thank you, Dr. Stacy.